Thank you. Hello and welcome to the inaugural Health Services Researcher Interview Series. My name's Rachel Morton and I'm a Professor of Health Economics at the University of Sydney and President of the Health Services Research Association of Australia and New Zealand, or HASRANZ for short. Today's interview topic is HSR during COVID-19. And my guest is Professor Harriet Hiscoll, who's a paediatrician and a research leader at the Murdoch Children's Research Institute in Melbourne, Australia. Harriet, thank you very much for joining us today.
My pleasure.
Could you give us a little background about the sort of work you do on a typical day, both as a clinician and as a researcher?
Yeah, Rachel, so I spend most of my time doing research now, and so my typical day is full of many meetings, as I'm sure many people would be familiar with. So I'm running quite a few big projects at the moment. One is an NHMRC Centre of Research Excellence in Childhood Adversity and Mental Health, and we're looking at community-based models of care that integrate health, social care and education to better detect and respond to family adversity and impacts of that on children's mental health. So I'm spending time, developing that model and co-designing it with my colleagues. And we'll have a hub in Sydney and as well as a hub in Melbourne. I'm also leading an NHMRC partnership grant to look at the impact of a shared GP paediatrician model of care to upskill GPs in their care for common high impact child health problems and reduce their referrals to the hospital system. And that'll be a stepped wedge trial across 22 practices. And then I'm doing other work in reducing low value care in children, models of care to keep children off our waiting lists, and looking at ways to improve access to mental health services and more equitable access for children as well. So my time is spent in those meetings, and then on Monday afternoons I get back to the real world and I see patients in my private rooms, and that's everything from babies through to teenagers, with quite a focus on sleep problems and mental health problems and developmental problems like autism and ADHD.
Right. So, Harriet, for people who don't know, what are the most common problems facing young people? What are the most common mental health issues that you see?
Yeah, look, ADHD is by far the most common, and we've only had 2 national mental health surveys for children, but the last one was around 2014-15, and that was the most common condition. That was closely followed by anxiety and then by depression. And often we see an overlap between those conditions in children.
Right. Okay. So we're in obviously a global pandemic at the moment. We have quite different conditions, both for work and how we live our lives. And I imagine COVID-19 has affected both your clinical practice, how you see your patients, as well as how you do research. Could you tell us briefly what have been the main impacts to your clinical practice?
Yeah, well, the main impact has been moving to telehealth. So really, I'm doing that as much as possible. And luckily to date, all my families are turning up and have been able to, manage the technology. And it's been really quite positive for some families in terms of being able to access healthcare from their own home and not have to get in the car, drive and find, a car park and all the expense and time that people need to take off their, life and their jobs to be able to do that. So for some families, it's been a really positive move, I think. And from a clinician's point of view, I get a little window into the family environment and I can see what is the level of chaos or otherwise going on in that family, which in turn feeds into my understanding of why a child might be having the problems that they're having and how to help them better.
And are there any things that you're unable to do via telehealth?
Yeah, look, I think the hard thing is I have had 1 or 2 children where I've been worried about their mental health and suicidality, and I've done those consultations face to face. I think they would be very tricky to do via telehealth. I haven't yet had a child coming for assessment of possible autism, but that's a big discussion amongst my colleagues. We have waiting lists 12 18 months to get an autism assessment in the public system. And currently those services have been closed down for multidisciplinary face-to-face assessment. So we're looking at models in the US where they've been doing telehealth assessments to at least start to understand what the issues are that a child might have and where early intervention could help. But the problem is that a lot of our wonderful allied health colleagues who do early intervention are not doing as much because they're finding that quite challenging via telehealth. So this is going to compound our waiting list for kids with developmental disabilities and issues.
So it's already 18 months, or pre-COVID-19, it was
Yep.
around 18 months, and you expect that it will be further delayed.
Yes, particularly that's the public system. There's a shorter waiting time in the private, but still, can be up to 6 months to get an assessment, a multidisciplinary assessment through private practitioners. And of course, there's out-of-pocket costs that families have to pay for that.
Yeah, absolutely, and very important. So how do you think COVID-19 has been affecting the impacts on children's mental health and well-being? Is there anything you see specifically related to the pandemic?
Look, I've seen a whole range. So I've seen actually really good impacts of children who don't have a good time at school. So there are children who get bullied or have learning difficulties, or maybe who are on the autism spectrum who really do struggle with social interaction. So they're actually enjoying being at home. So I'd say the introverts are happy often. And I have then seen the other, end of the spectrum, particularly for teenagers who just thrive on face-to-face contact. And I have a year 12 student, a final year of school, and they are really missing that face-to-face contact, knowing that they're in Australia with a great health system and they're quite privileged. I think where it's really taking its toll is in families where parents have lost their jobs, there's the financial stress, they might be single parent families, so there were already issues for that family, and this inability to send your child to school has been a very difficult thing because the pressure put on that parent to try and do some homeschooling and try and worry about the finances, etc., is just huge.
Yeah, absolutely. So do you see, in terms of research opportunities, and perhaps thinking about health services research opportunities in terms of service redesign or existing service when social distancing policies are relaxed? Do you see that there are any particular benefits that might be able to be carried forward in terms of how healthcare is delivered for young people?
Yes, look, I think there's a lot of things that we can learn. We talk about patient-centred care, family-centred care, but really we're often not. We expect families to come to us. So there's an opportunity to extend telehealth beyond the traditional regional remote Medicare reimbursement to make it reimbursable for all, if that's what families choose and clinicians choose to do. I think that would be hugely convenient for a lot of us. Kids have been largely unaffected by COVID, which is fabulous, but we've seen a huge drop-off in attendances at our emergency department and into admissions into the hospital. And some of that is because the lower urgency conditions that typically flood our emergency departments, parents we think are staying away because they're worried. So I'm hoping parents might learn a bit more self-care and care for their children and not rush to the ED unless they need to come. Obviously, social distancing has meant a reduction in infections that might trigger asthma, for example, or gastroenteritis. But I think what would be really good to come out of this beyond telehealth is opportunities for us to work together with our GP colleagues and our allied health colleagues. And our trial I was talking about is an in-person model of that, but there's really interesting models of care from internationally, so Project ECHO, the Massachusetts Child Psychiatry Access Program, where there's a combination of tele-mentoring or telehealth and resources and point of care clinical support that a primary care clinician can reach out and get from a specialist. And in turn, a specialist here in Australia, like a paediatrician, could reach out and get support from a child psychiatrist, for example. So I think we need to look at how we better get different clinician types working with each other rather than just some of the limited face-to-face Medicare funding options we've got, and think about how we do that because it benefits everyone in the health system that we've been able to show, from reduce hospital referrals, increase family confidence in GPs, for example, if the paediatrician's been working with them, and it reduces, the burden on the tertiary system as well.
So you're saying that multidisciplinary telehealth consultations or case consultations that involve GPs and specialists and families don't currently exist, or that
yeah, well, there's very strict definitions of what
a
a case conference is, and you have to have a certain number of people in the room to do that. So particularly I'd be interested in seeing models of care where the GP and a paediatrician could have telehealth together to do a secondary consultation with a family or to get advice. And similarly, from the mental health aspect, where a paediatrician could reach out to a child and adolescent psychiatrist, because we don't have enough of them in Australia. But there's no Medicare item number at the moment to enable that to happen, or any other form of funding. Yep.
Right. Yeah, probably a big gap, and sounds like an opportunity, definitely. So thinking about health services research and in your area, and in particular wearing the hat as you do for the Health Services Implementation and Improvement Committee of one of the ARTECs, the Melbourne Academic Centre for Health. What health services research do you see as facilitated by this particular ARTEC, and how has their response to COVID-19 evolved?
Yeah, so we've got a number of committees on our ARTEC, the MAC, the Melbourne Academic Centre for Health. So obviously the Infectious Diseases Committee has been very heavily involved through Sharon Lewin of responding with thoughts about treatments and treatment trials, and some of the basic understanding of the COVID-19 immunology. From the health services perspective, we're interested in what's happening to the care of acute non-COVID conditions, wherever the people gone with heart attacks and strokes. We're also interested to what seems to be a drop-off in primary care as well as hospital care for chronic illness, and does that matter? And that goes all the way from cancer screening. So my colleagues at the Victorian Cancer Centre are interested in delayed screening for perhaps breast cancer or prostate cancer. Is that going to ramp up down the track, and we're going to see people presenting with later cancers, more widespread or not? And has there been some over-servicing? There's a 40% drop in pathology testing for chronic illness. Does that matter? And in paediatrics, we can look at something like hemoglobin A1C in children with diabetes, and to see if they've had less contact with their specialist or less contact with their GP, does that actually play out with more severe or worse control of their diabetes down the track? And I guess the other wave that we're very interested in is mental health, and what is the impact of this pandemic now and going forward on the mental health of kids and adults. And for that, that's really more about setting up longitudinal surveys. But ideally, we would have, which we don't have in Australia, readily linked hospital and MBS data, so we could look at the use of mental health care outside the hospital walls for kids using MBS item numbers.
Right. So, so the measurement in terms of care provided, or care foregone, the changes in healthcare delivery, could be measured through linked data. And what about the outcomes? How would you measure the outcomes?
Yes. So we've been doing lots of thinking about that. Some of the outcomes you can measure readily through the existing hospital data sets. For example, are we seeing that our traditional maternal and child health nursing system, which offers free universal visits to mothers, that's gone to telephone calls only. So we can measure if there's been a drop-off in that use, and then do these mothers then turn up to the emergency department with a child, a baby, for example, who's underweight or is severely jaundiced. So, and similarly, we might say if a child hasn't been receiving their usual asthma care, are they more likely to end up presenting to the emergency department with an asthma attack that needs admission, or a longer length of stay, or admission to ICU. So there are some sort of proxy markers of severity, and for cancer it'll be easier in terms of using our cancer registries to look at are we seeing more late stage cancers. Yeah.
Yeah, I think that's terrific. So if you had the opportunity to have a couple of minutes with government research funders thinking about important health services research, what would you say to them, or what specifically would you ask for?
So I'd have three asks. One would be about extending telehealth beyond the traditional rebates for rural and remote patients. I would also ask, and I know there's work around this, but to really concertedly accelerate the efforts to link MBS, PBS data with hospital data, so we get a full picture of the healthcare system and the interrelated effects of healthcare on a patient's journey. And then the third thing would be coming back to thinking of ways of funding a much better integrated primary specialist healthcare system outside the hospital walls, so that we can really support our primary care colleagues and try and keep patients out of hospital.
Excellent ideas and initiatives, and I think with collaboration of lots of groups, I think they're really important messages, definitely. Harriet, just wanted to finally ask you, in this time of what is obviously a very pressured environment and very busy for yourself, how do you manage your own mental health? What if anything, are you doing to help look after yourself at the moment?
Well, I'm lucky that I've got a dog in the household, and I can say to my patients and my families, one of the cheapest psychologists you can get is a pet. So she's been having a lot of walks. My yoga teacher's doing Zoom yoga, so I do that on Wednesday nights. And we're lucky that we've got a veggie garden, so I've actually dug up a kilo of potatoes with my daughter and made gnocchi. And we've also gone online and bought soap making kits. So we've also made a kilo of soap. So,
oh, wonderful.
Yeah, I just do things that are completely disassociated from work.
Yeah, absolutely. Well, that sounds terrific. Well, thank you very much for your time today. And certainly from all of us at Hasrans, we wish you all the best, both with your health services research, which is extremely important, and also your clinical care of your patients. So thank you very much.
Thank you. Thanks. Now I can stop looking into the camera and look back at my...
Right, I know. Me too. I don't think that was too bad, but I've no idea as an objective outside. So
yeah.
I want to